welcome to Let's Talk About Mental Health. I'm Nels Kloster. I'm an addiction psychiatrist, and I work in Southern Vermont.
And my name is Robert Stack. I'm a drug and alcohol counselor and a licensed mental health counselor. Good evening.
Yeah, and we enjoy people's questions, so we just want to remind you how to contact us at our Facebook site at facebook.com/Let's Talk VT, or you could email us at questions@letstalkvt.com. Okay.
Well, you know, it's great to be here again. And last week we had the guest on, Beatrice
Birch with Inner Fire.
And Inner Fire, and she was talking a lot about, you know, getting off psych meds in different ways. And, you know, it was actually got a lot of good feedback from it. People enjoyed the show. And I have to admit that I still had some nervousness, you know, because when I was working in a hospital, and I would always caution people about being real careful about getting off meds. You know, sometimes it can be a risk factor for relapse into substance abuse. And just in general, it was almost like a mantra with me that, you know, maintaining good and healthy psychiatric care.
Yeah, stay on your meds, stay on your meds, stay on your meds.
Is good recovery. And so I've gotten more open-minded about it. But I still think that, you know, in some ways we ought to talk a little bit more about exactly how to do that, or some of the things that one should be concerned with.
Yeah, because it's, you know, I mean, we tend to sort of, I mean, I don't want to say fads in medicine, but we sort of get to a point where we think we have a good idea of how things work and what's the right way to do something, and then more research comes up that tells us, well, maybe that wasn't the right thing to do. And I think we still, like we've talked about many times with various, you know, guests on the show, you know, what's the right place for medications, right? With, say, Mary Ellen Copeland in the RAP program, with it has some role, but how, you know, responsibility is a big piece of your mental health care. Robert Whitaker, who we had on, who did some research that really portrayed medications in a very negative light, and the idea that maybe we've been misguided by the pharmaceutical companies. So, you know, we're at this point now, we're trying to feel our way through not knowing. You know, medications aren't always bad, they're not always good, and there's so many things that are healthy to help us get over things like depression, anxiety, that are not medications. But, you know, it's kind of a funny thing, when we talk about people coming off medications, I think that, you know, the one thing to say is that we should practice patience when we do that. I mean, it takes some time, not being in a hurry to do that, because a lot of folks want to just be, when they make this decision, they want to be done with them. And maybe it's a slick piece of marketing, but whenever we talk about medications for opiate dependency, like methadone and Suboxone, or, you know, even heroin or misusing medications, or we talk about some of the anti-anxiety medications, the benzodiazepines, right, like, so Klonopin, Ativan, and Xanax, we'll always, because those tend to get misused. There's a street value to those. People trade them. There's a, you know, sort of black market currency around those medications. And for those medications, we say that people have withdrawal. Now, if you were to ask, to look in the literature about stopping antidepressants, for example, so let's say, I mean, just Prozac being probably the best known, it increases levels of serotonin in the central nervous system or in the brain. And if you stop that, then that's termed serotonin discontinuation syndrome. So we put a whole different spin on that. But no matter what medication you might be taking, we tend to have what are called sort of, you know, homeostatic mechanisms. It's these sort of feedback loops. So if you think about maintaining the temperature in your home, the thermostat signals that it's too cold. It tells the furnace, you know, kick up the heat. When the heat builds up, then it tells the thermostat, okay, it's warm enough, now we stop this. And that goes back and forth in a way that keeps the home heated at a reasonable range. So we do the same thing with the brain too. There are, when you have an abundance of a certain chemical, then the signal goes back to say stop producing that chemical, and it goes back and forth in that way to keep what we call, you know, a homeostatic or a range that stays close enough to the same. And we know that taking medications, I mean, by design, might changes that balance, whether it blocks dopamine receptors as an antipsychotic medication, the medications for schizophrenia like, you know, Seroquel, Haldol, or whether it's an antidepressant that increases the levels of serotonin or norepinephrine or dopamine. But by doing this, we think this is great, this chemical is raised, but we never think about the other end of it. And that's when people start to have difficulties, because when you stop taking this medication, then the brain requires sort of a reset. If you will, sort of to tool back up the factory to produce those chemicals that it had sort of ceased producing because you're introducing them from the outside.
You know, in recovery communities, you know, you used to recommend telling people, you're not a doctor, you're not a pharmacist, you know, be really careful about self-will, be really careful about this idea, I'm going to decide my meds, I'll take them as I want them, or I won't take them, or I don't want to be on meds, and you know, and because I don't think it's real recovery. So that was always an issue, and I want to respect people's right to get off meds and have a better life, obviously. But I used to stress, and I think it's probably still true, don't do it alone. Talk to your doctor. Talk to somebody else. I mean, make sure that you're not just arbitrarily saying, "Oh, I'm going to stop my medicine," and without any kind of, you know, support, active support, working with somebody.
Yeah.
And I don't know if anybody would always get that message. I mean, I know, you know, sometimes, you know, you're sort of tempted just to say, okay, that's it, I'm not taking this anymore.
Right.
But I don't think that's a good idea.
Well, it's sort of the hard way of doing it.
Yeah.
I mean, if you think about, say, pain medications like, you know, oxycodone or Percocet, or when we use Suboxone and methadone for treating, you know, opiate addiction, if you stop those, there's a very distinct sort of syndrome that is very much like the flu, right? You have sweats and chills, and diarrhea, and aches and pains, you know, stomach cramping, and so people know from experience, whether it's from incarceration or losing a prescription, that that's a very uncomfortable syndrome. It's an awful flu. And it doesn't take very long to get that. I mean, for example, you know, let's say, you know, mom or grandma has a hip replacement, and let's say maybe it is more painful than thought, than anticipated, and they take the medications exactly like they were prescribed, and maybe take them for as long as 3 weeks. When they stop taking that medication, they will start to feel withdrawal. So we want to sort of differentiate here between the idea of being dependent on something as more of a physiological process. You can develop a tolerance, meaning you're exposed to it long enough, and then you have to sort of take more to get the same effect. Or having withdrawal means once you withdraw that suddenly, then your body responds, again, with this sort of upset in the balancing systems, that you start to become very uncomfortable. And that is something that doesn't mean that you're addicted. Having that withdrawal or tolerance is a very physiological process. But it is a process that we see with all the medications, whether it's opioids, it's benzodiazepines, even antidepressants. One medication for blood pressure called clonidine is very well known for having what's called a rebound hypertension, a rebound of high blood pressure. I see this with sleep medications as well, which is why I recommend you don't take them for a long period of time, because when you take them, sure, they help you to fall asleep, but then when you stop them, then you get sort of rebound insomnia. There can be a period of days, or if you've taken them for a long time, for weeks or months, that you can be feeling that rebound insomnia and basically not be able to sleep for having taken them for too long.
Right. So I guess I just feel better just mentioning that after, you know, last week and some of our discussions, you know, that again, you know, if you're on psychiatric medication or if you're on medications for addiction, you know, it's fine. You know, you can make a decision to stop, but you know, talk it over with your doctor, get a schedule. Yeah. I remember one person came in and told me they got off, I guess it might have been Suboxone or methadone, I forget what it was, but it was a very short period. And I said, you know, I'd probably recommend that you extend that, you know, if you're going to titrate down, you know, reduce your dosage, do it over 6 months to a year. Yeah. And they were more like, well, no, you know, I want to do it in a week or 2 weeks or something. And
I want to do it right now.
Yeah, and I applaud that idea. You know, I want to get it over with. I want to get it done. I mean, it sounds like something I would say. But really, the truth of the matter is, I think that it would be better if they took their time and just, you know. Go ahead.
Yeah, it's a little bit more so just pulling the Band-Aid off.
Right.
Right. Don't want to do it slowly. Don't so pull the whole thing off,
right.
because your body's going to take, your brain's going to take time to adjust to this changing in the balance there. And I think, like so many things, we get caught up in, no, this is what I want to do, and I want to basically get this whole thing done. And it's not necessarily, I mean, I don't treat it as rocket science. It's basically just listening to the body and going as slowly as keeps people comfortable, which then means that the brain is adjusting. And to not get so caught up on the destination, because some people might find that they're on a lower dose or less medications, but for a long time of life. The key is staying well,
right.
and to realize that medications are not sort of the most important piece of staying well, but they might be a piece of it.
Right, thank you. And I'm glad to hear you say that, because I think sometimes people see, well, if I'm on meds, like I said, I'm not really in recovery, or if I'm in meds, I'm too dependent on them or whatever. And I think that, in some cases, people need to be on medications. Yeah. And it's not for me to decide, like, well, this right. person or that person. But, if you want to get off your medications, and you're more than welcome to try it. But I would still be sort of like Mary Ellen Copeland, you mentioned before, the RAP program. You want to let people know that you're doing that. You want to talk about it ahead of time. Here's the plan. And the other thing I've noticed, that we've had patients, I've worked with patients who are on multiple medications.
Right.
I mean, so they were using different ones, and they need to be really careful about that. So,
yeah. And I think there's someone that I respect in this. It's a Vermont psychiatrist who was mentioned both by Beatrice Birch in the past and by Robert Whitaker, Sandy Steingart up in Burlington with the Howard Center there. And she's basically taken this approach to her patients and said, well, we really don't know. There's some idea that medications are harmful in the long term, and we know they can be helpful in short term or long term. And we'll share that with the patients, and they will work on this together. And I think that's really the right way to do this, because we're talking about a course of months or years, depending on how long you've been on the medication and which medication it is that we're trying to taper or withdraw from. So to develop that dialogue with the physician and the patient, and to do this together, I think is really an important piece to then maintaining being as well as you can remain during the period of taking off the medication.
Right. And having said that, I mean, I think it's the other way too. When people are put on medication, they should always be encouraged to develop a different lifestyle, or to develop other ways of coping, whether it's, when I'm on high blood pressure, I had to lose weight, exercise, or whatever it might be. And I think sometimes one of the problems I have currently with some folks is that they're substituting, or they're taking certain medication, but they're not really changing their lifestyle. They're really not changing the way they live. And so I think it's both of those things. If you're going on meds, you still should consider some other improvements in your life and your quality of life. So don't over-rely on the medication to make a difference.
Right.
And I mean, that's what I saw. I saw people who were on methadone or Suboxone, if they got involved with 12-step programs, if they cut back on certain activities or people and things like that, it wasn't just taking that medicine, it was really about changing their life.
Yeah.
And I think that's another way of thinking about it, both ways. Anyway, so the other thing I wanted to mention is a couple of weeks ago, and I don't know if I mentioned it here, got a call about intervention, about helping someone, a family member, and not my family, but someone called me about their family member, and it was sort of, I was thinking about it, and I'm very old school,
Right,
like
yeah.
A lot of what I learned, and even in graduate school, is now getting a little bit old. So I asked a friend of mine, I said, what's the best intervention? And he recommended somebody who's deceased.
Okay.
I mean, it's like, it goes way back. And, it's okay. It's the Johnson method, Vern Johnson. It's a book called Intervention, puzzle, I think by Hazelton. Mm-hmm. And, it talked about getting your family and friends together, rehearsing it, making sure everybody understands the dynamics of addiction and, and all that. And then talking to the person, and not in a confrontational way, but in a way that sort of expressed empathy, but also talked about the reality of it. And so, I just wanted to say that, there might be other ways of doing it, more current interventions, but I didn't find any. And I did look for it. And one of the things that I wanted to sort of share, and I hope you don't mind if I take a moment, what I find sometimes with interventions is that it's the family who's ready for change before the client is ready for change. And so a lot of times the interventions are sort of an acknowledgement of the program and an acknowledgement of the problem. Right. And here's a program, here's where you can go, here's where you can get help and stuff. But I think in some cases, and we've talked about this, from a stages of change perspective, it's almost premature.
Yeah. Well, it's become big theater these days, right? I mean, there's, it was HBO or Showtime, one of those kind of channels. They have a show called Intervention, right? They're gathering all these people together. They're doing it in front of the cameras, and they're following the people then through to either refusing treatment or going to treatment or leaving treatment early, and following that whole thing and interviewing all the family members around that. And well, I mean, the very little that I've looked into it indicates these things are not very effective. And I think if we think about our work in the sort of long-term perspective, I can see why it's not. I mean, it's such this, it seems to be embracing the idea of sort of cure and big bang sort of all at once, fell swoop sort of treatments, which we know are just not sustainable usually.
And they're fairly rare events. And I mean, I'm happy for the ones that happens. My family intervened, I went to treatment, I picked up again. But I would say for most folks, and I've worked with lots of folks who came into the hospital back in the day when we had people for 4 to 6 weeks. They would come in and their family did an intervention. We'd have a private room for them, or maybe a double. But here you are, and they would spend a week or two mumbling, grumbling about their family, or going about like, well, I didn't want to be here, but blah, blah, blah. And then you would figure, well, in the 3rd or 4th week, maybe we can change his mind, get him more involved, and then by the 5th or 6th week, we actually get him actively working on his recovery and send him out the door. Well, nowadays you don't get that much time.
Right.
You're not in the hospital that long. And the other thing is, and you just mentioned long-term, short-term. I think sometimes if you're successful in the intervention, you get them into treatment. But there's a good chance that when they leave, it may not work. They may relapse. Or the opposite may happen. You may not get them into treatment, but long term, it might be worthwhile intervention in that you highlighted that it was a problem.
Right.
So I guess I'm sort of doubling back on this, but I just wanted to say that sometimes the outcome is not what the people who arrange the intervention want. But it's probably worth the effort. It's probably worth trying it. It's probably worth letting the person know that what they're doing is not, they're not getting away with it. Yeah. It is an issue and a problem. But I would really tone down the expectations. Yeah. I would really be careful about what are the expectations.
Yeah. Well, I think if we look at sort of what's the meaning of the word intervention, and on one level with this sort of attention to this sort of big production sort of an intervention where everybody comes together, you go to treatment, you get well. That's more sort of more modern connotation for it that we have now. But if we really look at sort of the work we do, it's constant interventions, and it's much sort of like, we say interventions with a small I instead of a capital I, because nothing that any of us does is passive. I mean, if a family member says, I think you have a problem, that's some sort of intervention and action there. When they come to treatment, or, if I'm their physician, I think they drink too much, I say something about it. That's sort of trying to intervene in the process, rather than letting it sort of take its natural course, which could mean, stopping the problem by yourself versus dying from it. I mean, so we're trying to then always intervene to sort of stop that worst case outcome from happening.
Right, and sometimes you're tempted to believe that if we get them like doctors and airline pilots have good outcomes out of various treatment centers because they're highly closely monitored and they have a lot to lose if they relapse their way of life and money and everything. But if you looked at the history of ball players, if you looked at the history of movie actors, if you looked at the history of people who have access to a lot of health care, people who get assigned people to watch over them.
Or access to a lot of temptations.
Yeah, I mean, whether it's movie stars or whatever, and they really have comprehensive aftercare, and they have the whole thing. And it's really, quite frankly, it's not that successful. Yeah. I mean, an addict or an alcoholic, and you can watch them for a little while, and you can keep track of them. But my experience has been when you're staying clean and sober because somebody else is watching you closely.
Yeah.
It's not that easy to make that transition to when they stop watching you closely.
Yeah. I have one of my colleagues I work with in Bennington is always talking about if we keep throwing pillows down in front of them, they're going to have these soft landings, and it's not going to accumulate. It's not going to make sense. So if you're a Hollywood star and they're wiping your nose for you, that's not going to you're not going to put out the kind of effort that's going to take to really get some kind of change going.
Well, you know, I had to admit it, but I'm a New York Mets fan. You know, and like Darryl Strawberry and Dwight Gooden. I mean, really great treatment. You know, they would interview them and they would talk about how well they're doing and all that. You know, and they relapse, and it was a lifelong struggle. And I often, you know, I worry about it sometimes, and I've said this before, and I know I'm repeating myself, but sometimes what I've noticed with families is that early on, families go through a lot of strain and money and resources, and it's a very difficult time for them, and they try and get that person well. You know, it's like, okay, and whenever they're unsuccessful, it sort of wears them out, and they get sort of like burnt out almost. And often you'll see, if it's a couple, I mean, even if they're divorced, but if there's like a mother and a father involved or something, they'll begin to argue among themselves about what the right approach is, or like whose fault it is, or why didn't you do this, or why can't we do that. And I think that's so sad, because in a way, not only is it being destructive to the individual, the addiction, but at that point it's starting to attack the family. Like you'll hear other children say, you know, what about me? You're not paying attention to me. I'm not doing it. And everything's about him, and all the money and all the concern is about the child who's using, or, you know, the young adult. So I think it's a really difficult time for families. And I think that, you know, sometimes when this one person was talking about they're going to fly in somewhere to do an intervention, and they had to put up X amount of money up front, you know, and, you know, it was like, oh, that was kind of scary to me, because I didn't think that was going to work well, but I didn't know how much to say. I mean, you know, truthfully, I really didn't. I mean, you know, sometimes I worry that I'm not hip. I'm like, what's going on? And I don't know enough about what's going on. But it just seemed like they were getting sold like a promise, you know what I mean? With enough money invested, we can make a difference.
Right, which is not the case. I mean, like the old expression, you can lead a horse to water, but you can't make it drink. You know, all this money and effort and flying in intervention stars to push somebody to treatment, if the person's not ready, then that's the wrong intervention for that person at that time. And maybe to think across, going to be talking about sort of stages of change, that people are in pre-contemplation, which means they're not thinking they have a problem, to contemplation, they're starting to consider with all these people intervening and telling me these things, maybe I have a problem. And then the sort of the preparation action phases where, okay, you know, I have a problem, I need some help, please direct me. So, you know, early on, the intervention is not sort of get in the face, bring the family together, you know, push them to treatment, but it's simply saying, I'm there, I don't like your drug use, we're not going to tolerate it any longer, whether you think it's a problem or not. And maybe the right intervention is telling them to go live on their own. And
beginning the consequences, and beginning to acknowledge the consequences. And, you know, beginning to acknowledge the, you know, what are the limits, like you were saying, and how we're going to deal with this, and how this affected me. And I think that's all good stuff and good practical interventions. But I just wanted to say that. I was really scared. I mean, sometimes it's a lifelong struggle. There's no quick and easy answer. If a family member of yours, you know, goes to treatment once, gets an intervention, gets well, then you got your miracle. I mean, at that point, you know. But for most of us, it's a struggle.
I mean, because we're coming from our professional background. I mean, most families are not prepared to do this, and so to be able to say something to the effect of, you know, I love you, but I don't like your drinking. And the person that you become when you're drinking. So therefore, here are the boundaries. Here's what I will take. Here's what I will not take. You know, something I can teach you, like Al-Anon is a good place for picking that up. Most folks are still, oh my God, I care about my family. I want to rescue them. I want to help them get better. And it's very hard. I mean, some people call hard love, if you want to use that expression, but kind of learning the right thing to do. I think intervening with the family would probably be a better strategy than intervening with the actual family member.
And then measuring progress differently. What is the progress that I'm making? What progress are they making? Instead of they're on a downhill slide, maybe we hit a plateau. And maybe we're starting to make some changes going back the other way. And I think that's another way of looking at it. Like you just said, absence, and a lot of times I used to hear parents say to me, I just want her back the way she used to be. And I would caution them that I don't think that's going to happen.
Yeah.
I mean, they really need to grow and change, and they're not going to be the way it used to be, but hopefully it'll be something new and different.
Yeah,
now, having talked like this for the last 10 minutes, I would like to talk about the wonders of recovery and what it is a privilege to see people who get better and see people who change.
Yeah, I mean, I should be embarrassed, but I had a pretty good week last week, because we do this work, and we work with hundreds of people, and you do it over the course of years. And people ask, well, how do you keep on doing that? And I mean, just this week, for example, last week, I had this woman come in who's been struggling for a couple of years. I mean, so much to the point where sometimes I wonder, am I helpful, or am I, say, enabling or hindering anything from happening? And we finally got to this point where we had this very serious conversation, made some substantial changes, and that on top of the other work and struggling and suffering that she has done, just things came together, and she made some very important decisions. Right, so once she stopped smoking pot, and has done that for a couple of months. Sort of laid down the line with a partner, and that partner's responded to that, and now within the course of just a couple of months have this situation where all of a sudden home is better, income is better, the social circle around them is better, because now they're starting to push away people who want to trade drugs and reward you with a pill or something like that. And it's just to think that it can take so much time and so much effort before something finally comes to fruition or results. There's just, it never stops being really gratifying. And also when that moment comes, and like, yeah, you know what? I feel great. And you have that feeling that it's sticking, that it got to the point where it's like it's down to the bone. Yeah. That this is something that's going to really be the foundation for things getting better. And so those kinds of moments, I don't know about you, but it's that kind of, I need that every now and then, not too often, but when it happens, I'm actually so happy for this woman and her family.
Oh yeah, and when I worked in the hospital a lot of times, and I think this actually happened to the field in some ways, we ended up focusing on why people relapse, because these same people were coming back and they would relapse, and it almost seemed like that was the focus of was relapse prevention, relapse.
Failure.
Instead of looking at the people who were successful, the people who got into recovery, but because we'd only see them once. But I tell you, the highlight of in my little world, is I'd be in a supermarket and somebody stopped me and say, I don't know if you remember me, but you worked with me 20 years ago and I've been doing well. We forget about the people who get better, and not that we forget them, but we don't see them again. Their life goes on, they get better, their life gets better. So I know that in some ways, we have to talk about relapse, and we have to talk about the people who struggle. But there is recovery from addiction. There is recovery from mental illness. There is a quality of life that people achieve, whether it's PTSD or depression or anxiety. And we don't often talk about them enough. I don't think that to acknowledge that.
Yeah, and to realize that most people evidently get better on their own, right? They don't seek professional help. They come to the realization that their lifestyle is not working for them, whether the result of that lifestyle has been drug use, addiction issues, whether it's maybe depression or being anxious, and taking some concrete steps to change happens much more often than people actually seeking any kind of treatment. So we do have this, I think we've mentioned this before, what's called a selection bias. If everybody I work with has the worst levels of addiction and other mental illnesses, then I start to think that everybody's like that, and we forget the bigger picture.
Right, and people get better with the right medicine. People get better with joining 12-step fellowships. I mean, but it occurs over time, and it's a journey of recovery. Yeah. And I just want to make sure that we don't miss that sometimes. The positive.
Right. Stop sprinting. It's really it's a marathon. It's a long distance race.
And be grateful and thankful for the little small victories that we have. Right.
Right.
Okay.
Absolutely.
Thank you all.